Hi, everybody. This is Tara Gomes again. I think we're going to get started. Thank you all for joining us for this presentation to give you a bit of an introduction to the Prescription Opioid Tool. We thought that after having had it released for a little while now, it would be worthwhile for us to have an opportunity to speak with people who are using the tool to give you a bit of an orientation to it. We've had some questions about how best to use it, and so we wanted to give some examples of that as well as just walk you through the navigation so that you understand the full scope of what you can do with the tool. A couple of more kind of administrative pieces for you, just to let you know that everybody has been muted. There are upwards of 200 people signed into this webinar, and we wanted to avoid the interruptions and hold music and other things that can happen to make sure that it works well for everybody. So everybody has been muted. If you have any questions over the course of the presentation, and at the end we're hoping to have about 15 minutes for questions, please just type them into the chat box, and we have one of our colleagues here who is going to be capturing all of those questions and then reiterating them to us so that we can answer them for you at the end of the presentation. If we don't get to all your questions, we'll also just send out a document after this is done with a bit of an FAQ based on what comes up during the hour. The details here are just for logging into the webinar and the audio. So I think there were a couple of questions of people having a bit of trouble joining, but hopefully you have had that resolved, and if not, there's some tech support happening in the chat right now, so we should be able to get that all resolved. In the interest of time, we're just going to move forward and get started with the main content of the talk today. So for those of you who don't know me, I guess I should introduce myself. My name is Tara Gomes. I'm the Principal Investigator for the Ontario Drug Policy Research Network, and we're the group that has put together the Ontario Prescription Opioid Tool. So what I'm going to do today is just give you a bit of a high-level, very quick overview of our group and specifically the development of this tool and why we went about doing this. I'm going to just remind everybody of the indicators in the tool. I'm guessing many of you were participants in a similar webinar that we had at the outset of starting this tool development, where we were trying to get input on which indicators to include. What I'm going to do today is just give you a sense of the indicators that we've landed on and some of the evolution of those in the time since the tool was released. I'm going to then pass over the presentation to my colleague Diana Martins, who's going to provide a walkthrough of the actual tool just to give you a sense of how you can navigate it and some of the tips and tricks to using it well. And then it'll come back to me, and I'm just going to go through a few examples of how you might be able to apply this data to policy and practice. As I mentioned earlier, there have been some questions around how best to use this data. There is a lot of data here, a lot of different ways of seeing it and using it, and we just wanted to start to plant the seed as to some ideas of ways that they may be, this data may be useful to you, and hopefully kind of get some conversations started amongst yourselves as to the best way to use this. And then finally, like I said, we'll hold about 15 minutes at the end for questions. I saw one question I'll just answer quickly. The ODPRN stands for the Ontario Drug Policy Research Network. We're a research group funded by the Ministry of Health and some other grants with the key mandate of really generating high-quality information in a timely manner to inform drug policy decision-making at the provincial level, and some of the work is also used at the national and international level as well. One of the things that we really aim to do is foster innovation and try and make sure that we're using data in a way that is very valuable to scientific thought leaders, to policymakers, and to ensure that the data that we generate is of high rigor so that people can really rely on it and use it in their decision making. So just to give you a bit of a background and a context to where this all originated, one of the first things we did in this field of something that looks a bit like the current tool was the development of a report that looked at opioid use and related adverse events in Ontario. This was more of a static report. It was kind of a PDF report. At the end of it, we had a report card for each of the health units, and we did have an online interactive map that enabled people to look at some basic indicators of opioid use and adverse events in Ontario. So that was our first attempt at really trying to generate some of this data that would be valuable at the regional levels in Ontario. One of the things that focused on was using the publicly funded drug data to capture prescribing of opioids, but we knew that wasn't capturing the full picture. So we worked with the ministry to secure the Narcotics Monitoring System, which allowed us to look at all opioids that were dispensed across the province, and then worked on a big public report to try and give everybody an idea of what opioid prescribing really looked like in the community in Ontario. This came out in a report we called Behind the Prescriptions. And this is really a summary of what we knew to date around opioid prescribing. It had a number of interactive maps as well for a few different indicators that allow people to try and understand opioid use across the province. But one of the issues with this, again, was that this was a snapshot in time. So we were generating these maps for one period in time. And what we were repeatedly getting was questions around how are these indicators changing? What is the most recent information that you can provide for us? And that wasn't something that was possible with these more one-off reports that we were creating. Around this time also, it became, I think, much better appreciated across the province that there was a need for ongoing surveillance to try and address the opioid crisis that we're in right now. And one of the really valuable pieces that came about in 2017 was that Public Health Ontario released their interactive surveillance tool that was really focused on describing the fatal and non-fatal opioid-related overdoses that occurred in the province. And when we saw this tool, we saw how valuable this could be in providing up-to-date information at the regional level on some of the adverse events associated with opioid use across the province. And so what we did was we secured grant funding from CIHR with a component of that to be for us to create a similar companion surveillance tool that would describe opioid prescribing in Ontario and would give us the resources to update that on a regular basis. So that's basically what we went about doing over the past year or so, which was to work with a variety of stakeholders, many of whom, thank you, were, I'm sure, on this call and participated in prior conversations with us and webinars to give us your advice on indicators. What we've done is we've been able to present these indicators from July 2012 onwards because that's essentially when the complete NMS data is available to us. And like I just said, we are largely using the Narcotics Monitoring System so we can get a population level estimate of how opioids are being prescribed in a community across the province. We are also using the Ontario Drug Benefit Database, and that's specifically to look at naloxone dispensing across the province because that database does capture all naloxone dispensed in pharmacies. So that's a newer indicator added to the tool and uses that database. And our plan has always been to update this surveillance tool quarterly. We last updated it at the end of November, and we will be updating it again in March. I'll talk a little bit more about those updates and the recency of the data at the end of the presentation. We've had some issues with the data feed from the ministry that meant that we didn't have as much data as we had hoped, which is going to delay slightly our next release, but the next release will have a large chunk of data in it, so it'll get you all up to date. Like I said, I'll mention the details of that later. So what I first want to do is just quickly talk through the indicators to give you a reminder of what we're really capturing in this tool. The first two outlined here are pretty basic. They're the number and rate of people who are dispensed an opioid. The first indicator is specifically opioids that are to treat pain, and the second is opioids to treat cough. Within that bucket of opioids to treat pain, that's really the category of opioids that are used most frequently, and we have also provided data specifically on the type of opioid and the formulation of opioid that is dispensed. So you can get a sense of codeine, fentanyl, hydromorphone, et cetera, dispensing across the province, as well as long-acting versus immediate release opioids. The third on here is a newer indicator and is specifically related to pharmacy-dispensed naloxone kits. So as you probably all know, Ontario has a program called the Ontario Naloxone Pharmacy Program, the ONPP, which provides publicly funded naloxone to people if they go and ask for one of these kits from a pharmacy. So we can capture that data in the ODB database, and now I've incorporated an indicator of the rates of dispensing of these kits across the province. That program came into place in June 2016, and the data became available for us to present starting in July of 2016 until the current time. The next indicator relates to volume of opioids dispensed. So the first indicator around opioids to treat pain was the number and rate of people So, 300 people per 100,000 population, for example. But sometimes people want to have a sense of the volume of opioid dispensed. So how many milligrams of morphine or equivalent are being dispensed? Because a prescription for 3 Percocets or 3 Tylenol 3s is very different in terms of the amount of opioid in that compared to a prescription with 100 hydromorphone tablets in it. So we also present the data by milligrams of morphine or equivalent to get a sense of the volume or community load, some people might call it, of opioids being dispensed. And then because high dose dispensing has also been an issue for many people, we have an indicator looking at the number and prevalence of people who are being dispensed a long-acting opioid that has a high daily dose. And the thresholds we use for that are 50 and 90 MMEs, as well as 200 MMEs. And those are because of the thresholds that are in the current and past Canadian guidelines. And then the last few indicators are on this slide. The next one, number 6, relates to treatment for opioid use disorder, so specifically methadone and buprenorphine, which we call opioid agonist therapy. And so we have an indicator that captures the number and rate of people who are dispensed one of these treatments, which can give you a sense of the prevalence of people being treated for an opioid use disorder with one of these drugs in your community. We also knew that there were questions around access to prescribers who were able to prescribe one of these medications. And so we have an indicator that captures the number and rate of OAT prescribers. And this is adjusted to the number of people who are actually being prescribed OAT in the region. And that's presented both overall for OAT and then also stratified by the type. So we can look at the prevalence of prescribers for methadone and buprenorphine separately. And I'll get into an example at the end of the presentation around where I kind of see the value in being able to have that stratification. That was one of the questions that actually came up after the release of the tool and led to an update, because we saw that that was quite a valuable piece of information for people to have. So just a couple of final notes now that you have a reminder of the indicators before I pass this on to have Diana walk you through the navigation. I wanted to raise for you the issue of small cell suppression. This is something that is a privacy requirement for us when using data housed at ICES, and basically precludes us from reporting any numbers or counts that are less than 6. And this is all detailed in the technical appendix that you can get on our website. But I wanted to just remind you of this because you might sometimes see gaps in your data, particularly if you're in a small region or a region that has a small population. And I wanted to just make sure everybody understood what this means. So essentially in this table on the top row, you can imagine this is some original data. So for example, counts of people who were prescribed an opioid for pain. And you can see that in the 0 to 14-year age group, there was a count of 3. So we would not be able to publicly report that number. And so we would censor it in the second row to less than or equal to 5. However, if we reported the total of 50 and the less than or equal to 5 there, by basically adding up the rest of the columns and subtracting that from 50, we could figure out that value of 3. So one of the other requirements we have to do is something called residual suppression, which means we take the next smallest number, which in this case is the 9 for the over 65s, and we also suppress that number. That means that nobody can figure out that less than or equal to 5 number because of those 2 cells being suppressed. So that's something that we have had to do and go through with all of the data whenever there are small cells, make sure that they're censored and that we do residual suppression to make sure that nobody can figure out what those small cells are. And that's really just to protect people's privacy. In terms of how this looks in the tool, it can look a bit strange. So here are a couple of examples just to give you a sense. The top row here is what you might see in the Trends tab, where you might just see a gap in your figure where there's no data shown at all. So any of these suppressed cells will basically come up as missing in the data. So here you see a trend over the first few months, and then you see a gap of data, and then you see the trend pick up again. And what that means is that the data between those 2 lines has been suppressed, either because it was smaller than 6 cell size or because of residual suppression. So it had to be suppressed to stop us from disclosing a small cell somewhere else. In the second part of this figure, you can see what happens in the age sex tab. So the columns that you see on the right, there's one column that's missing. If you hover over it, which you can kind of see, it's very small here, but you can see when you hover over, you get an information bar, and it will show that that basically is a missing or suppressed cell. So you know that in that case, again, it was a small cell size or residual suppression. We can't share that piece of data with you. And so finally, the last piece is just to remind you of some of the tool features, and Diana is going to show most of these to you now as she walks through the tool. Just to remind you, data is available for download, so if you see a figure and you want to create it yourself or get that data so that you can use it in conjunction with other information you might have, you can do that. You can hover over information in order to actually see what the data is related to that point. You can select just certain components of a line chart to show. So in the line chart by drug type, you can just select a few of the drugs and only see those lines if you're only interested in a few different comparisons. So those are a few of the tool features. I think Diana will touch on most, if not all of those, in her walkthrough now. And the link to the tool is just here in case you don't have access to it. But we would ask as we go through this walkthrough that you just kind of focus on the presentation, and then you can play around with the tool when this presentation is done and you have a little more information. So now I'll just pass this over to Diana.
Thank you, Tara, and hi everyone on the line. Just going to escape this presentation and direct you to our website to start the demo. So just in terms of accessing the tool, when you do arrive to the ODPRN main website, we do have a link to the tool featured as a highlight on our website. Although this does click through and go through other highlights on our webpage, so if you miss it, you can also access the tool by selecting Opioid Drug Observatory on the top bar and clicking on Ontario Prescription Opioid Tool. You can also easily reach this page. If you Google ODPRN Prescription Opioid Tool, you should be able to find a link to this website. Once you do reach the landing page, we do include background information on the tool, along with a link to Public Health Ontario's interactive tool on opioid-related harms. We also include more information on the Narcotics Monitoring System, which is the database where we use information for our indicators on the tool, all of which except for naloxone. Now, directing you to the resource bar on the right, we have a link to our reference guide, which includes more information on how to navigate the tool and is essentially what I'll be walking through today. And we also have a link to our technical appendix document, which includes background information on the indicators on the tool, as well as information on any small cell suppression we had to undertake. We also have a copy of our email address here. If you do have any comments or questions that we weren't able to address today, you can always feel free to reach us here. Navigating you to the left, we do have a suggested citation that we ask you use if you are using any data or figures from our tool in any public-facing documents. And this just helps us measure the impact of the tool and also measure how the data is being used. Now, if you scroll down the page, this is where you will reach the opioid surveillance tool. I'm going to switch over to Tableau, which is the program we use to create the tool just to help with performance. So once you do reach the tool, you'll notice a set of tabs across the top. This essentially presents different ways of viewing the data. I'll walk through each of these tabs, but I'm just going to start with the Trends tab right now. The first item I want to draw your eyes to is the Geographic Area drop-down menu. This is where you can select how you view information. The default is for Ontario, but you can also look at information by LIN and by public health unit. And just noting that this drop-down menu does scroll down, there is quite a long list of regions, so if you don't see your region, just remember to scroll down the list. The second drop-down menu here is for the indicator, and this will change the figure based on what indicator you want to look at. The default here is the number of individuals who received an opioid for pain. If you're ever confused about what indicator information you are looking at, I suggest you refer to the y-axis label, and this will include information on the measure you're looking at. So right now we're looking at the indicator opioids for pain. The y-axis indicates that this is number of individuals. We do present information by period, so we have yearly numbers, and if you hover over the data points, a pop-up box will appear, which will include more information on the time period you're looking at, the indicator you're looking at, along with the count. So right here we see that there are about 1.6 million individuals in Ontario who received an opioid for pain. We've also allowed monthly estimates, and this allows us to present more recent data. For example, the annual accounts we can only update at the end of the year, but the monthly numbers we can update on a quarterly basis moving forward. It's also helpful for determining seasonal variations over time within a particular year. For example, if I do select opioids for cough, we know that there is a seasonal pattern in how these are used based on individuals getting coughs throughout the year. So if you do highlight over one of the data points, you can see that the opioids for cough is higher among the winter months. I'm just going to go back to the opioid for pain indicator and mention that you can also graph the information by count and by rate. So the count here is useful for looking at the magnitude of people or prescriptions for opioids. But if you switch to rate, this will then adjust the count for the population in a particular region. So for Ontario, this is the number of individuals receiving an opioid for pain per individuals in the population of Ontario. If you refer to the y-axis again, we do provide more information on how this is calculated. This rate is presented per 1,000 population just to provide a better number that you can interpret. Again, just mentioning that you can hover over any data point. I'm just going to select the pharmacy-dispensed naloxone indicator. You'll notice here that the data only starts in July, and it extends to September 2018. So the difference in data availability is due to the naloxone indicator being obtained from the Ontario Drug Benefit Database rather than the Narcotics Monitoring System. So we're just trying to update the tool with as much data as we have available, so you might notice these changes in data availability. Scrolling down, we do have a note section below each figure, which includes some important methodological details we wanted to include when you are using information on the figures. We've just highlighted a few notes here, so more information can be found if you refer to our technical appendix document. Now, scrolling back up, I'm going to jump to the drug type tab. This tab includes trends over time as well, and it includes information for opioids dispensed for pain. The measure here is number of individuals, and the data available is only by year. Again, highlighting that you can select a geographic area of interest, so if you want to select the LIN or public health unit. We also have a new drop-down menu option here, which includes looking at opioids dispensed for pain by immediate release formulations and long-acting opioids. For example, on this figure here, we do see that codeine combination and oxycodone combination products, which are immediate release formulations, are the most commonly dispensed products to individuals. But you can limit this figure to looking at only longer-acting opioids and view how the trends change over time. You can also adjust the graph by count or by rate. And one feature I want to speak to here that's available across all tabs is that the legend is dynamic. For example, right now we see hydromorphone being the most commonly dispensed long-acting opioid for pain. However, if we select hydromorphone, we can exclude this from the figure to get a better sense of how the other long-acting opioids are being dispensed in the province. So there is a back arrow at the bottom of this figure when you are on the website. So just directing your eyes to the back arrow here. So I'm just going to go to the drug type and then go back to long-acting opioids, select hydromorphone, and you can select exclude. If you scroll down, you can use the back arrow and the image will update and add hydromorphone back to the figure. Similarly, if you want to look and zoom in on a particular opioid, you can select that opioid. So for example, long-acting fentanyl, and you can select keep only, and this will update the image so that you can zoom in on fentanyl and look at how that is being dispensed over time. Again, scrolling down the page, you can always use the back arrow to refresh the feed and update the image to what you were viewing previously. Moving now to OAT prescribers, we've kept this on a separate tab due to the way that the denominator is defined here. This is presenting count of OAT prescribers, and if we adjust by rate, this will adjust per individuals receiving OAT. Again, on the left, we do have the geographic area that you can locate, so you can choose your LHIN or public health unit. And a new feature that we added in November was you can select prescriber by treatment type. This will pull the number of OAT prescribers and break it down by what opioid agonist therapy they dispense. We include methadone only, buprenorphine, or both treatments. And similarly, if you are interested in focusing in on only one of these lines in the image, you can select the line of interest and press keep or exclude. I'm just going to go back now to the age and sex tab. This tab presents information quite differently. So we do see on the left a figure of trends over time, and then on the right we do see a bar chart that presents age and sex stratifications in one time frame. I'm just going to switch back over to Tableau to continue the demonstration here. So again, we do have the geographic area available where you can select information for. You can select the indicator of interest, which will update these images, and we provide the count and rate. And again, just easy insights that you can take away. When you are looking at count for individuals who received an opioid for pain, we do see that this is highest among individuals aged 45 to 64. However, if we do select rate, this will adjust for that baseline population of individuals by age group and by gender. And here we do see different trends with increasing rate of use by age and the rate of use being higher among individuals aged 65 and older. One feature on this page is that you can show data by age or also by sex. So in the drop-down menu for show data, you can select overall by sex and also by age group and sex. This will add females in the purple and males in yellow. Now, if we look at trends over time, we can draw some insights here with the rate of use for prescription opioids being higher among females. However, if we are interested in looking at opioid agonist therapy prescriptions, we can see different trends with increasing use here and the rate of use being higher among males compared to females. One other feature on this page is that for the trends figure, you can select the drop-down option and select a particular age group to focus in on. And for the bar chart on the right, you can change the snapshot that you are looking at information for between 2013 and 2017. Finally, I'm just going to move on to the Maps tab, and this is intended to provide geographic variations in the indicators in Ontario. On the left, you can select that the map be broken down by LHIN regions or by public health unit regions. The PHU regions do provide more breakdowns in the province. Similarly, you can select indicators that you want to display the map for, and I just want to note here that all indicators is presenting the information as a rate. So we've adjusted for the population in the LHIN or PHU, and this just allows us to make comparisons between regions. You can also select to view the map by different years, and the heat map here for the rate is fixed over all years. So if you do select 2016, you might see that the map is shaded darker compared to 2017, which would indicate that in some regions, the rate of individuals receiving an opioid for pain has decreased from 2016 to 2017. For this map, you can hover over any region of interest and a pop-up box will show up with more information on the region you are looking at and the indicator rate. If I hover over the darkest region here, we see this is North Bay Parry Sound District Health Unit. The year is 2017 and the rate of use is 165 per 1,000 individuals in this population. You can then compare this to some of the lighter shaded regions on the map. For example, if we pull up Toronto Public Health, we find that the rate of opioid use is approximately half of that what we previously saw, so about 86 individuals receiving an opioid for pain per 1,000 population. Now, one last feature I want to speak to, just flipping over back to our website, is that when you are looking at any information on our tool, you can download the data. For example, right now we're looking at the map for opioids for pain. You can click on the image, scroll down, and then there's a download button that you can press. Once you press that download button, there's a few selections for you. You can select to download an image, a PDF, or the data itself. When you do select download the data, it will only download information for what you are actually looking at. So in the map that we had up, we were looking at information by LIN, which is the geographic area and the data output. The map indicator we were looking at was for opioids for pain, which is what is outputted here. The year would be all years that were included on the map, and the average value here would be the rate for the indicator opioids for pain. And I just want to reiterate that this information is available across all tabs. So if you are looking at trends over time, you can just click on the figure, scroll to the bottom, and press this download button, and you will get the same information that you were looking at. So that concludes my walkthrough demonstration of the tool. I'm going to pass this back over to Tara, who will speak more to using the data to derive insights for policy and practice.
Thanks, Diana. Pull the slides back up. Okay, so what I wanted to do now is just walk you through a few examples of how you might be able to use the data that Diana showed you in the tool to try and inform some of the decisions or discussions that you're having. So one of the questions that people might have is, are we seeing changes in preference or practice as it relates to opioid prescribing or opioid treatment across the province? One of the ways that we could look at this is, for example, looking at the rate of opioid agonist therapy dispensing across the province. So the figure on the left here is the overall provincial rate of methadone and buprenorphine dispensing. And you can see some general provincial trends. So we see that buprenorphine dispensing has been increasing over the past 5 years or so. And we also see that methadone, while increasing slightly, has perhaps started to plateau or even decline a little bit in the most recent year of data that we have. So we see some different trends between these two treatment options at the provincial level. But I think what can also be very valuable here and helpful is seeing how that does or does not correlate with what people might be seeing at a smaller level, so at a public health unit or LIN level. So, for example, we pulled up the Northwestern Health Unit data for the same indicator, looking at the rate of OAT treatment, and you can see a really different pattern. So you can see that methadone, the rate of methadone use perhaps is similar to the province in that it was climbing for a while, and around 2016, 2017 it started to plateau or decline a little. But what we actually see that's most interesting, I think, is the buprenorphine trend, which is that it has been increasing much more dramatically. And by the end of the data that we have available to us in the tool right now, in this region of Ontario, there's a higher rate of buprenorphine dispensing compared to methadone dispensing, and that's certainly different from what we see at the broader provincial level and speaks to what we know to be differences in the way in which people access different OAT modalities across the province. So in more rural or remote areas, people may be accessing buprenorphine instead of methadone because you are able to get longer carries, and so if you don't have quick access to a pharmacy, it would be a preferred method of OAT. So you can compare provincial trends to more local regional trends to see how your region might compare with the provincial average, or you can compare it with other regions, neighboring regions, or regions that might have similar population profiles to see how you might be similar or different as it relates to any of the indicators in the tool. Another really interesting piece to add to this is the issue of OAT prescribers. This can build on the story that we just saw in the last slide, in that we can actually look at the changes in how people or how physicians and nurse practitioners are choosing to write prescriptions for methadone versus buprenorphine, or those who might be treating people with both of these products. So you can see most strikingly in this figure is the buprenorphine line, which demonstrates that there has been a huge increase in recent years in the number of prescribers who are treating people with buprenorphine. And this, I think, aligns with what we know, because there's a smaller group of methadone prescribers in the province who treat kind of a large number of methadone patients, but a smaller number of prescribers, whereas people are pushing more for buprenorphine to be rolled out into primary care, for example. And in that situation, you would see a larger number of prescribers of this drug who might be only treating a smaller handful of people with the product. You can also use the maps to try and understand how OAT, just to kind of follow on in this example, differs across the province. So on the left hand, what you can see in this map is the rate of people who are being treated with an opioid agonist therapy in 2017 across the province. And on the right, you can see the rate of OAT prescribers adjusted for the number of OAT-treated individuals in the province. So I think comparing these is pretty interesting. And, you know, if we focus on the central line, which is, I think, the that's the Northwestern Health Unit, I believe. Is that right?
Thunder Bay.
Or Thunder Bay? Oh, geez. You're testing my geography here now. But if you look at that, basically that region with very high rate of OAT dispensing or number of people treated with OAT products, they have the highest rates in the province. So you might expect to see a large number of prescribers also working in that area, but what you see is it's actually one of the regions in Ontario that has one of the lower rates of OAT prescribers. And so I think that that's helpful, because it also highlights the fact that perhaps that region has a risk of, if you lose one or two prescribers, having a problem for all of these people who are being treated with an opioid agonist therapy being able to access that product, because it might be more sensitive to changes in that prescriber population. So what you can do is kind of compare the prevalence of treatment with the prevalence of prescribers to get a sense of the ways in which people might be accessing these treatments. And in northern parts of Ontario, it appears, at least in some of them, that a large number of people are accessing treatment through a small number of prescribers. Obviously, opioid-related harm is a really important issue, and one that we care a lot about in trying to figure out how to address this issue. We don't incorporate indicators on harm in our tool specifically. However, one of hopefully the nice things about our tool and our attempt to design it in a way that is very similar to the Public Health Ontario tool is that you can then compare between the tools. So here's an example of understanding opioid-related harms, where we could look at naloxone kit dispensing from the ODPRN Prescription Opioid Tool on the left across the province at the health unit level in 2017. And you can pull up opioid-related death rates, again in Ontario at the health unit level in 2017 from Public Health Ontario's tracker. And then what you can do is look at areas where perhaps there are high rates of naloxone dispensing that correlate with high rates of opioid-related deaths, and that is where you would like to see a lot of opioid or naloxone dispensing, because there's clearly a lot of harm happening. But you can also identify, so for example, in the Hamilton-Niagara region in southern Ontario, there's a bit of a cluster of high rates of opioid-related deaths in that part of the province. But if you look at the naloxone dispensing, they're kind of moderate to low rates of naloxone dispensing. So you might be able to also identify areas where there is a high degree of opioid-related mortality and perhaps not a high level of naloxone dispensing, where there might be gaps, and perhaps there could be efforts to ramp up naloxone dispensing in those areas. So by having both of these tools available and similarly designed, hopefully it allows for comparison across tools as well. You can download the data from both of the tools as well, so it allows you to kind of merge the data on your own between the two tools if you'd like to. And then another potential application of this tool is thinking about how you might be able to impact the introduction of policies or programs that have been rolled out either at the regional level, community level, or at the provincial level. An example of this that we did was an evaluation of the fentanyl patch for patch program, and we did an evaluation of that province-wide. There's a screenshot here of the report that came out, and you can find that on our website. But one of the things that that you can actually do in this tracker is look at trends in volume of opioid dispensing, types of opioids dispensed, to try and see whether the timing of introduction of a program might have impacted some of these trends. So if we take the example of the Leeds-Grenville United Counties Health Unit, we know that they introduced their patch-for-patch program in February 2016. If you look at the monthly rate of milligram morphine equivalent, so the volume of opioid dispensed in that health unit over time, you can see that around February 2016, early 2016, there was a reduction in the total volume. So that kind of horizontal line starts to decline around the time of the introduction of the fentanyl patch-for-patch program, which could imply that the introduction of this program actually led to some change in the amount of opioids that were being dispensed in that region. You can then look at the figure by opioid type, which is in the lower part of this slide, and you can actually look at the fentanyl line specifically, which is the purple line here. And while it's hard to see explicitly in this figure, you can actually see that around between 2015 to 2017, there was a decline in fentanyl dispensing. So you can start to piece together the fact that after introduction of the patch-for-patch program, there seems to be changing volume of overall opioid dispensed, and when you look at the types of opioids dispensed, that seems to at least in part be explained by reductions in fentanyl dispensing. So that gives you a bit of a sense of the way that you might be able to use this data to evaluate programs. So those are the examples that I wanted to walk through, just to give you a bit of an update on what to expect with the tool. We will be releasing a March 2019 update. The exact date in March is yet to be determined. We're just waiting for the most recent Narcotics Monitoring System data to be linked to ISIS. As soon as that is completed, we'll be kind of running our code and getting this up as soon as possible. So stay tuned, and you should see updates on that tool in March. That update will include data between April and December 2018, so you will have data up to the end of calendar year 2018. So at that point, we'll really only be a couple of months out of date. So hopefully that will give you some up-to-date information for any of the work that you're doing. And then a new addition to the tool that we will be incorporating is that there have been questions that have come to us around our naloxone indicator, asking us to stratify that indicator based on the type of naloxone, so injectable versus intranasal naloxone. And so with this next update, we will be stratifying our naloxone indicator into those two types, which will allow you to look at uptake of each of those two different forms of naloxone over time, which I think will be helpful as we're seeing more and more intranasal naloxone being used. So stay tuned for that, and we'll share links and try and get word out about that update as soon as it is completed.